Good afternoon. Good to those on the East and I guess the Central Time Zone. If you are a little bit further west, good morning to you. I am Eli Fleet, Director of Government Relations at HIMSS, and wanted to welcome everybody to this webinar presentation that HIMSS is working in partnership with TeleTracking on. This is a second conversation to one that we had at Global Conference in Orlando around the healthcare delivery ecosystem, and as part of our learning lab. So the idea that we will put out some sort of white paper document where HIMSS and TeleTracking will work together, kind of get feedback and provide potential policy or next steps kind of moving forward. A couple housekeeping things so that today's conversation can be a free-flowing conversation with our panelists. We are using the meetings feature of WebEx, which means that everybody's lines are open, and available for sound. So I've asked if you are not talking to please mute yourself so that we can limit the background noise. We will also be using, if you have questions, you can use it in the chat box or raise your hand, the raise hand feature in Zoom, so that we can ask the questions. Michelle, our moderator, will help us through there. So with that, I want to turn it over to, like I said, our partner here, Bill Lovell of TeleTracking. Bill.
Thank you, Eli. Appreciate that. So I'm Bill Lovell. I'm the general manager for TeleTracking. I'm the general manager for TeleTracking Government Services. We have a really great panel today for an incredibly important and relevant topic, I think, to all of us in the healthcare industry. So as Eli pointed out, we were very fortunate working with HIMSS to be able to have a really exciting face-to-face discussion around visibility of capacity and care coordination with a separate and different group of panelists that covered sort of military health, veterans health, and commercial healthcare. And it was really stories of how things went over the last few years, issues identified, challenges identified. And this panel is much more focused on techniques and technologies and how you put those technologies and techniques together in order to actually solve those problems and overcome those challenges and to actually take care of the most important thing in our world in healthcare, which are our beneficiaries, our patients. So very excited to introduce Michelle Skinner as our moderator. She's a vice president, one of our nurse executives, preeminent in this space. She'll be working with a panel of esteemed colleagues across the TeleTracking space. So Dr. Doug Rosendale, Susan Kilgore, Paul Davenport, all executives who are actually living this fight every day to take care of our patients across the nation. So without any additional comments from me, over to Michelle.
Thanks, Bill. Appreciate that introduction. We have only 60 minutes today, so we're going to dive right in. First, the topic we're going to talk about today is high reliability organization principles. So high reliability organizations, or you'll hear to us refer to those as HROs. So those principles, there's 5 of them, and for some of you, this is probably just a review of information, and for some, this may be new information. So we did want to ground in that first part of the conversation as to what those principles are. So the first principle is a sensitivity to operations. What does that mean? It's that heightened awareness of the state of relevant systems and processes. You're going to hear our panelists talk a little bit about what that means in real life, in the real life world. Number 2 is the preoccupation with failure. So viewing those near misses as opportunities to improve rather than proof of success. So really looking through at those opportunities, those near misses through a different lens, instead of saying, yay, we made it, we got by the skin of our teeth, looking at that as an opportunity to improve. A reluctance to simplify. So acceptance that the work is complex with potential to fail in new and expected ways. So not trying to assume that we have, that there isn't a complex world. A commitment to resilience. So prioritizing emergency training for the unlikely possible system failures. This is likely one of the things that folks have been the most familiar with, where we do disaster drills or tabletop exercises. So creating that familiarity for those unlikely events. And then last, a deference to expertise. So valuing the insight from staff who have the most pertinent safety knowledge, rather than just those with the greatest seniority. So seeking those who have the most relevant information, rather than just those who have the most seniority. That is something that is well developed within many of our organizations. And then lastly, before we dive into the questions, we're going to talk a little bit about the HRO, high reliability organization strategies. And there was a fantastic evidence brief put out by the VA that really consolidated a number of different opportunities for information. A lot of different sources kind of brought that information all together. And the 5 things that they came forward with were that for importance was developing leadership. So number 1, developing leadership. Cultivating a culture of safety, so quality and efficiency is that, in addition to safety, is that patient flow conversation. Ensuring training and learning, so that 3rd piece is training and learning. 4, implementing interventions, and 5, data systems. So as our panelists answer their questions and they interact with each other, you'll hear them referring back to both the principles as well as the implementation strategies of HRO. Everybody ready to dig in? We'll let each of our panelists briefly introduce themselves as they answer their first question. I think that'll be a really nice way to do that. So I saw Paul earlier this week in his command center. The one behind him is fake, so just a backdrop, but it does really look like that for anybody who's ever seen Curlion's command center. So Paul, I'm going to ask you a quick question, but before you answer it, if you'll just give us a quick introduction to who you are and what you do, and then we'll dive into your holistic ecosystem engineering question.
Great, thank you, Michelle. My name is Paul Davenport. I'm the Vice President for Emergency Services and Care Management Service Line at Korean Clinic, a health system in Virginia. And I have background in aviation, EMS, and Operations Center Science.
Wonderful, thanks, Paul. And I know you had, we talked about this question in advance, and we actually wove some of this into our conversation this week. So this will be fantastic feedback. And other panelists, please feel free to jump in after Paul answers his initial question, because I'm sure you all have examples of this. And I will do my best to try to keep time so we can make sure we get through all 5 of these examples. So around the concept of holistic ecosystem engineering, if you consider the complexity of healthcare operations within individual organizations and across ecosystems, addressing part of the problem results in suboptimal outcomes and unintended consequences. It also can exacerbate the problem, making things acute or systemic. So if we look at an intentionally holistic, purposeful overlap and redundancy as a HRO principle and strategy, can you give an example of what that looks like in your health system? Sure, and if I may, I'll go backwards just a little bit to put context around the answer, if that's okay, Michelle. Peter Drucker once wrote, healthcare is the most complex system on earth, which means it's more complex than air travel, which seems pretty complex these days. Maybe nuclear power, NASA, SpaceX, perhaps Elon Musk will take issue with SpaceX as well. But we are a highly complex ecosystem. And when we say ecosystem engineering, I think of it as seeing the system as a whole, rather than a group of departments, a group of hospitals, or however different clusters or components of a system is made up of. These interdependencies have relationships, and we must acknowledge the complexity in these systems. It's like a spider web. You pull on one side of the system, it changes, there's failures, there's different things that impact your healthcare spider web.
And these things create what our COO at Carillion Clinic says is noise or friction for the most important thing, which is our patients. So really the creation of this and the high reliability principles helps us address this complex animal that we call healthcare. Now, I won't go over those principles. Michelle, thank you for covering those, but I'll bring up a couple of those and a direct example. At Carillion Clinic, our executive and senior leadership have acknowledged system complexity, step one. And put systems in place to manage the system, not oversimplifying decision-making while being decisive in their actions. They've also ensured leaders understand these principles and fighting what we call a natural tendency to reverse HR principles. Those principles are not natural to human behavior. So we have to work at them to become sensitive to operations, preoccupation with failure, reluctance to simplify, commitment to resilience, and deference to expertise. So one may say really if we left at our natural state, it's really the opposite. Human behavior tends to be simplification, not reluctance. We tend to yield to expertise and then undervalues potential failures as well. All of these things our system has acknowledged and takes great stakes to make sure the leadership team at least understands that. So let me just focus on just one HRO principle, sensitivity to operations. What you see here is one of the first healthcare system operations centers. It leverages technology, people, and processes, allows for high situational awareness, cross-departmental communication, informed decision-making, and agreement on standard processes and protocols. Again, that helps us reduce variability at our system. Combined with huddles and other communications that are routine in many systems, it allows everybody to have the most current information and communicate that information across the system. We use the data and information to track and trend. I think there's another question coming up later on, so I won't cover that. That's very important. But over time, our system has evolved, learning from success and failure, so resiliency. Becoming a team of teams. Retired General Stan McChrystal talks a lot about team of teams, and one that we highly recommend and educate our leaders here at the health system on. And we have one mission, acknowledging that complex systems are competing priorities. So for one person to be successful, somebody else may have to fail or not achieve their results. So in our healthcare systems, it is very challenging. Our executives also understood that if somebody is yielding for the ultimate patient goal, that it doesn't seem like a failure if they've had to give up on something or perhaps a project or in their department. Managing the unexpected is another component that the system has focused on leadership and leadership development. With preoccupations of failure, what happens on plan A, B, or C, and then asking, what if this doesn't work? Or even if this is designed correctly, again, acknowledging there's complexity. As leaders, we're encouraged to speak up and challenge the status quo, so not yielding to expertise. One time in my career, I'm allowed to do that. And at the end of the day, our health system has been on a journey learning and growing. And I think that's the most important component here is understanding this is evolution, always acknowledging that HR principles are at play. And we are human, so the system is naturally pulling on that spider web. Thank you, Michelle.
Fantastic. Lots of great information to build on. And I know our panelists, as we move into this, they're going to pull on some of those spider web strings that you just talked a little bit about. So that's going to be fantastic. Just one quick housekeeping item. For those who have their mics open and are not speaking, could you please mute those? And then secondarily, just know that there are no additional slides. This is discussion only. We will have a lot of opportunity at the end for conversation. So I think you're going to hear lots of places where your own health system may have have these examples, or where you may want to ask the experts, so to speak. So, and certainly we will all pull together to do that. So wonderful. Thanks, Paul. Appreciate that. Dr. Rosendale, you are up next. And so if you would love, I would love it if you would not mind introducing yourself briefly, and then we'll dig right into your question.
Thank you, Michelle, and thank you everybody for joining. And it's really great to see a lot of names from my prior time in the VA as well as the private sector. Great team out there. So let's make this exciting. Just by way of quick background, I'm a surgeon by training, but I became a geek about 2001. And they trained me to be an informaticist for the VA so I could help VA modernize and develop the electronic health system. That led into some relevant background for this conversation. And I'll give a shout out to some of my colleagues in VA and Homeland Security. They pulled me into a White House disaster preparedness and prep group. And so a lot of the work we did with medical public health information systems became some of the guidelines for Homeland Security and how we manage disasters like this pandemic. And what's relevant here is this pandemic actually revealed to me later on in my career, when I finished out 20 years as a chief of staff and medical director at the Western Colorado healthcare system, that we needed real-time information systems, tracking, and being able to manage complex situations and staff and PPE and vaccines and everything else. And so I became a CMIO for a VA DoD Interagency Program Office about 10 years ago. And all of that led to this point where I recognized that we need information systems and change management solutions and the ability to actually track our patients through the workflow, track our patients in and out of the medical center, and track all our resources. And so I'm really looking forward to this conversation, and I look forward to your questions.
Thanks, Dr. Rosendale. So the question that we have for you is talking about leadership. And I know leadership within the military infrastructure as well as within the VA may be slightly different than the leadership outside of that area. So I think it'll be a fantastic way for you to weave the threads between them. And we appreciate your expertise here. So if you consider that executive buy-in and sponsorship with clear operational structure and division of responsibilities, including empowerment, escalation, steering committees, and the role, and potentially even the role of the state departments of health and emergency response organizations and regional considerations. How can leadership be cultivated across the healthcare delivery ecosystems to promote the HRO principles?
Interesting how you frame that, because I have been experienced with leadership in both the private sector, the VA, and the Department of Defense. And the cultures are all slightly different, but the main premise is that in any complex system, like Paul suggests, we need the ability for leaders to actually lead at every level of the organization. And it's really important to empower those leaders so that they feel supported, they have the buy-in from their staff, and there's no name, blame, and shame. It's what Dr. Stone, Rich Stone from the VA, as the undersecretary, promoted as a high reliability organization principle is you need to have the ability for a just culture. So if any of you out there read the book Good to Great by Collins, they almost left the CEO chapter out of the book. They didn't think they needed it, but they did figure out that the CEO actually creates a just culture, a culture where people feel comfortable and they can actually excel. So we need leaders at every depth. We need leaders that have a succession training program. Education and training is constantly happening. Through this pandemic, it became crystal clear to me as a chief of staff or chief medical officer that we needed leaders for every aspect of this complexity. And we needed leaders to reach out to other leaders. I was actually texting daily with our 4 other hospitals and 20 other hospitals in the region about what their load balancing is for the pandemic, et cetera. And so leadership is the key component to any high reliability organization. Dr. Stone also mentions that you need a safety culture. It's all about safety and anticipating where errors happen, avoiding the Swiss cheese examples of mistakes, et cetera. And then also understanding that the dynamic always changes. The ability to adapt to process improvement on a real-time daily basis is critical. Sometimes we get stuck in our old ways of policies and procedures. This pandemic showed that we had to change every single day based on the guidelines. And so we need nimble systems, information systems that give us the intel we need to make those kinds of decisions. And I know there's a data question coming up later, and I can talk to that even in more length.
Fantastic, Dr. Rosendale. I think I heard you hit on almost every HRO principle in there. You know, definitely a preoccupation with failure, reluctance to simplify certainly was one that I heard several times, and that commitment to resilience. So wonderful. I look forward to the next conversation about data. Susan, you ready to introduce yourself? I'll see you next week. And if anyone's ever been to San Antonio, Susan's command center or her care control center, she'll say it for me because she just changed the name. She's got this beautiful umbrella of events underneath there. Susan, you want to do a little introduction before we dive into your question?
Sure. Good afternoon, everybody. I'm Susan Kilgore. I am the Regional Vice President of Operations and Patient Placement for the Methodist Healthcare Division in San Antonio. I'm honored to be at Methodist Healthcare. This is my 34th year that I will be here with Methodist, and my background is emergency nursing. And as Michelle alluded to, our journey really started back in 2009. We are 8 hospitals in one healthcare system, Methodist Healthcare in San Antonio, but we all operated independently. We really had no idea what was going on in our other hospitals. While some were very busy, it was hard for transfers to get in. We were missing some of our evidence-based measures, and we just really didn't have a way to communicate. And so at the time, and it kind of ties everything we've been talking about with leadership, our leadership really wanted to solve what was going on in our division and all of the silos. So we embarked on what we opened and called a patient placement center or a transfer center using the teletracking technology. And what that allowed us to do was to see all 2,000 beds as one, all patients that were waiting, able to look at, when you talk about safety of the patients, where are your patients that are MRSA or any isolation issues? Where were our heart alert patients? Where were our stroke alert patients, our core measure patients? That allowed us all to bring it together and have visibility. We also started sharing metrics for placement, EVS turn times, how are we doing to turn over beds, transfers coming in. But the biggest part was to be able to create capacity and decrease the ED holds and be able to accept more patients. We had to really work on the middle part of it, which was throughput leading to discharges. So again, the data, the center seeing everything, we were allowed to work on moving our discharges from later in the day to earlier in the day. It's still a lot of work in progress for that. But as we kind of fast forward and looking at what we've learned and grown, we really merged into a care coordination center. So early on, you know, it was all about how fast sometimes could the transfer center or placement center do things. And sometimes we weren't getting the right specialists involved. We weren't making sure we had the right medications at the certain facilities or the right equipment. So we've really, over the years, have advanced to be more care coordinating and getting that care, what we say, started at the time of patient entrance into the hospital, or if it's a transfer at the time of the phone call, assuring that we have that safety net to catch the patient. We used that process and that really strategy as we started moving into putting emergency management in our organization more forefront. Being in San Antonio, we don't get impacted a lot by disasters, thankfully. But when hurricanes do hit along the coast, we are always a receiving center. So we really got good at identifying who could discharge now, where we could create capacity, what we could do to provide other areas additional support in those situations. That moved emergency management into the care coordination center as we touched on that. And then in 2020, as we experienced COVID, we really progressed much further and really have turned into not only the care coordination, but really the operations center. And that was driven by our leadership. It was driven by giving autonomy and empowering our patient placement coordinators, who are all nurses, empowering leadership to do what needed to be done and make the change. So our physicians actually stepped up during COVID as everybody was struggling with who do we test, how do we test, are there enough tests? And that all got delegated to our command center. So we became the coordination center or air traffic control, however you want to refer to it, for all things COVID in our healthcare system. All surgical COVID patients were tested, called to us, who then we shared results, made sure physicians known, and just have progressed. Each pandemic, each year, as we get more, we just keep progressing in what we can do for our healthcare organization to keep culture, keep safety all in the top. We've cared for over 28,000 COVID patients. We have cared for the most COVID patients in our region. But we also took that experience, how we do throughput, how we level load, how we manage, to our STRAC, our regional level of our racks, to share with them our processes and to take some of that into how we level load for our region.
That was beautiful lead into the question we have for you. So Susan's initial question is to talk about the culture of patient flow, quality, safety, and efficiency. So that HRO strategy of quality, safety, and efficiency, and how do you, knowing what your clear definition of your mission, your vision, and your objectives are, how do you embrace that continuous learning and improvement with all the things that you've talked about? And how then do you align that mission, vision, and objective within your ecosystem outside of the COVID environment? So you've talked with me and many others about how you take those same principles and ensure that they work on day-to-day operations.
Sure, thanks. So, as I mentioned, how we got to where we're at, we are constantly looking at data and having a vision of everything that's here. So if you're familiar with TeleTracking, we see all 2,200 beds, but it's more than that. We have the OR schedules, we have the cath lab schedule, so we know what the true needs are. And what we found is communication is the key. Our clinicians in the facility are so busy caring for patients that sometimes they don't have the time to look ahead or to know what's occurring. So when we talk about safety, being prepared, we have alerts built where we send out to the facilities from our staff what's holding, what the needs are, OR schedules. We send those a day ahead of time. We target patients to units so they know the morning of early how many patients that they have to bed that day. We communicate discharges as well, so they know what's coming in. And then a lot of it too is sharing what is out in our market outside of our healthcare system that don't have the resources, and how do we bring those in as well. So we have communication through our technology as well. And then we look at length of stay. One of the things that we do in our centers, we staff with all nurses to write orders, so they can write some of the time-sensitive TPA, CTA, whatever those evidence case measures are, sepsis alerts. Sometimes they're not recognized when we're getting a call for a transfer that the patient is sepsis. Our nurses are trained to look at vital signs, temperature, lab, and then be the one telling our physicians that we need, this patient's a sepsis alert and they haven't ordered antibiotics. So that care really starts before they get here.
Excellent. Paul, I know when we talk about similar operations within your command center and that sensitivity to operations, I think about that high reliability organization principle. There's several of them we just hit on, but sensitivity to operations, that preoccupation with failure, reluctance to simplify. I just think about the similarities that we have between, sort of the escalation during times of COVID or other times of disaster, and then the ability to draw that into day-to-day operations. Do you have any thoughts on that?
Well, I think it's important because the foundation that Susan's really talking about is really, it gets put to test during times of pandemic or times of stress or an emergency management scenario. So again, I think the foundation element here is that we're always learning and we're always trying to promote either a sensitivity to operations, meaning that one side of this room may get some information. It may not be very high on their radar, but the person sitting right next to them who has a different role, it is very important for them. So you almost sometimes in these rooms that we talk about, you almost overhear certain things instead of training a human, which you can't, to learn everybody's job and then, and try to what information needs to be passed on. So it's like a fusion center sometimes that's referenced in the literature where information's coming in, it's on boards, it's in the air. And then you'll watch rooms like this begin to interact and communicate. They'll get up, they'll walk. So, some things can be done on chat. Some things require someone to turn around and communicate that. Some things are totally done on technology and that they could be done at their desk, if you will. But I think it's highly important it's the combination of these elements that make the rooms that we talk about, these command centers or these care centers, really work and really deliver the high reliability results, which is what really matters.
Fantastic. Thanks, Paul. Dr. Rosendale, we're about to dive into what I know is near and dear to your heart, and talk a little bit about data, and how that ties back into high reliability organizations. And I know that Susan and Paul will have lots to add on to this as well. So if we think about how you define, track, and trend metrics, KPIs, ensure that enterprise visibility, do you want to talk a little bit about data and what that has, how that's been integrated into the work that you do, and especially in both the VA and Department of Defense, and how that's integrated into that high reliability organization?
Well, as you might imagine, hearing Susan and Paul talk, I have command center HRO envy. During our time, during the pandemic, as a medical director these last couple of years, we had unbelievable people in the VA tracking and trending and gathering data from all the various resources. The government's really good at capturing data. Whether or not the data is relevant is sometimes in question. But what I learned from Susan and Paul is their experience with their formal command center systems were able to harness that information in real time to make real-time decisions without having to hunt and peck and create spreadsheets all over the place. And so we actually tried in VA with Power BI and some other web applications to create a command center concept. I didn't know that the teletracking concept even existed back then. But part of my retirement was recognizing that, gee, there are really big systems out there that support, HCA, Ascension, Intermountain, big companies, and they actually have a good handle on it. What I did discover, as you might imagine, as a surgeon who became a geek, is that information and data are key to a high reliability organization in order to create efficiency and safety and effective care and care coordination. You need all that information all the time in order to make those decisions. During the pandemic, just understanding the availability of supplies like PPE, vaccines, staffing, space, load balancing with our non-VA partners was critical to managing our care. Applying all those lessons learned into how we run an operation, an enterprise daily, became quite obvious. If you look at the airline industry with air traffic control, you look at the energy industry with managing all the energy sources. If you look at any industry, even the sports industry, tracking RBIs, they have real-time data making smart decisions. A colleague of mine, Dwayne Keneva, wrote a nice paper. It's in draft form. He said I could share it, but it's all about a national health reliability organization. And how do we get from where we have siloed systems and not a lot of sharing to a integrated, interoperable, transparent system of systems where all provider organizations are sharing the right data. We're fortunate in America. We have health information exchanges, and we can share a lot of clinical data. We have a lot of financial and other administrative data systems that are working, not necessarily associated with the clinical systems. Wouldn't it be nice if we had financial, administrative, clinical, and other guideline systems like from the CDC and FDA all integrated and reconciled across those systems? We found during the pandemic that the guidelines from FDA, CDC, VA national, VA regional, all these systems were all over the place. And wouldn't it be nice to have a central core ability to harness these guidelines and turn them into something actionable? So in my retirement, I'm still on mission to help transform healthcare. And I believe that strong care coordination and command center solutions is the future in order for us to have a high reliability nation.
Yeah, that's fantastic, Dr. Rosendale. You know, when we think about the work that's happening in these command centers, oftentimes one of the underlying themes or goals is that shared situational awareness, right? So how do we make sure that everyone has access to the same information at the same time that's appropriate to whatever level of work that they're doing, so that they can make coordinated decisions? Paul, Susan, any thoughts on that?
Yeah, you know, the data, I think that you hit on it. The data is really what helps us drive our operations, our process improvement as well. Part of how we, you know, service lines that when we started this in 2009, that we did not have in our healthcare system. But being able to, one, care coordinate, have a central center where every patient who transfers out to another acute care hospital goes to our care coordination center, we were able to track that data as our out-migration data, our leakage, however you want to apply to it. But then we were able to take that and really look at what services were we missing and add those additional service lines in. Or as we work with our RAT, how to identify those service lines or needs that are not in our area today, and how do we help bring that there? I think the other thing is, you know, we have lots of reports that go out every morning. The system is very data rich. And I go back to when we were in our peak of our COVID surge, our highest surge, we had 548 hospitalized patients. And when we got to 100, 150, you know, we realized that we needed a surge plan beyond our normal surge plans that we really have. And our goal was, we thought we were going to get to peak at 600. And so how did we find phases to get us up to 600 COVID beds? Where were we going to put them? What units were we going to convert? And we really were sitting there thinking this was going to take us days to do. And with having all of the data-rich environment that we have in TeleTracking and their new product Synapse, and we've had this, you know, since 2009, it took us maybe a couple hours, if that, to have our surge plan that then we used from our very first surge in 2020 still today, where we were able to surge up and surge down really within 24 hours because we had all that data at our fingertips and can convert that.
Excellent, Susan. Thanks. Paul, anything you'd like to add to that?
Yeah, I think that, you know, Susan really teed it up very well on, you know, building a surge plan using data so that you're not, you know, stringing things along or multiple pieces of paper or, you know, urban legends that are throughout healthcare systems. You know, one other, maybe just a different a lens to look at as well regarding data is, you know, the boards that you see up in our centers, you know, some of those boards are become almost like wallpaper to you. Like, you know, there's certain boards that your brain gets trained on immediately. And one of the things that we found during the COVID surge that you've heard from both of the panelists as well is that we needed visibility immediately on where the patients were, where the capacity was, how many patients are in emergency departments, and, you know, depending on how many hospitals that are in your system, and what's the current state of each one of those hospitals. And Susan really referred to that in the capacity plan that they developed. So it's incredibly important to be able to do that. And again, the software and Synapse with TeleTracking allowed us to do it in the same hours that Susan was talking about building a capacity management plan regarding COVID. So immediately we were able to pivot, provide additional data streams, put it inside the system. And that was going to not only our executive leadership, but our senior management team, and being able to be put up on boards inside the center. So now everybody had the same information, and you didn't have to call people. You didn't have to even perhaps, have a conference call to discuss that. And many times people were already referencing some of the streaming data sources that we have, because you could hear them quoting the numbers that only they probably have on that source. And so, other pieces of the analytics to be used are, more report driven. So they may not be, great to put up on a screen, but they do come into your email box and or attachment, and you can look at those and really look at that. So one of our senior vice presidents over the large tertiary care trauma center in our system would use that immediately to determine his plan for COVID capacity management at the trauma center. So, all these systems that we put a lot of energy into, it's great to see when those analytics can come, they can serve our patients and serve the people in the system for easy, quick decision making. You also got rid of anybody's assumptions, because that was the source of truth. And so the other key component here is everybody has one central source of truth, and they begin to drive towards that and not have multiple sources that provide confusion.
Paul, thank you. And Susan, that was wonderful. I think we talked a lot about sensitivity to operations, significant amount around preoccupation with failure, and ensuring those data systems provide that reluctance to simplify, right? So understanding this is a complex situation, complex environment, and have that opportunity to ensure that we will look for ways to fail in new ways, that we're trying to preempt that. So trying to understand where that will happen before it actually does. You both led into the next question, which is around training and learning. And I do want to leave a little bit of time here. So we'll try to integrate this one with our next one, Paul. So around training and learning, Susan, Paul, and Dr. Rosendale, I'd love for your thoughts around all of this. We'll let Susan get started. But Susan recently was she already told you she's in San Antonio. So there, the practice of the disaster drills or other high profile drills are to provide them that opportunity to create the culture of safety, training and learning and preparation, so that we can have a calm, cool head and when that actually occurs. Susan, do you want to talk a little bit about how you train the staff on operational excellence and patient flow, specifically how you use simulations and exercises to prepare for normal and emergency operations? And then Paul and Dr. Rosendale, I'd love for your thoughts on this as well, because you're all coming from very different situations.
Sure. And I think that Paul hit it earlier. It's one source of truth. And so for us, the key is reducing variability and having an operational platform that is the same throughout our division. We'll tweak it a little bit for each individually of the hospital, but then everybody is taught through either hands-on, rounding, what our strategy is around patient flow, how we're going to operate in a disaster, how we use certain units. And then we have a lot of mock drills, of course, with our region, where we get to put it in play. And then we've had quite a bit of experience with the hurricane and then with the pandemic. And the thing is that you have to have what we've taught our staff, and it's newcomers and our leaders, is you've got to stick with your processes. And at the time of crisis and need, you don't avert from your processes. This is where your processes really lead you to that next step. And that's what we have found, but it's just repetitive every day with physicians, with leaders, with your own staff in the center, and then your nurses out on the unit as well.
Fantastic. Paul?
I think that some of my previous careers really provided good training and background and materials to help bring those forward to the Operations Center leadership and then the other teams that are here at Korean Clinic. My background is in firefighting, also in pre-hospital EMS. I was an ER nurse and then a flight nurse in aviation. And so bits and pieces of that all along the way. And I think, Susan's background is also in emergency nursing, and where you have to be planning all the time. You have to have different plans. You have to pivot. You have to reassess. You have to be able to do multiple things at once, and you have to be able to disconnect and then continue to move forward. And then if something didn't happen correctly, then you have to be able to reflect and say what you're going to do differently. There was some mention about just culture as well, and that training is essential because as humans, we have a natural, maybe we're raised this way, where if you do something wrong, you're going to get in trouble, no matter whether it was your fault totally or not. And so really trying to infuse some of those principles. In my aviation days on Korean Clinic's lifeguard helicopter, we were taught the importance of checklists and following procedures. Susan commented on the importance of making sure you're following your procedures, because if something happens, if you're not following your procedure or we don't go back to it, we can't tell what happened. We just know the outcome. And so the importance of training on your procedures and having procedures in place and having formalized structures to not allow procedures to be changed on the fly. At our organization, if you're going to change something in the operations center or procedure, there's a stepwise fashion you have to go to. It goes through a committee that's swift but understands the fact that you just can't send a memo saying effective immediately, this is how we're going to do it, and everybody prints it off and puts it in a 3-ring notebook and is supposed to follow it. So we're highly protocolized. And then lastly, I think from my aviation days, is we were taught to always scan our environment, always be looking at the instruments in the helicopter, always be scanning the horizon to look for any obstacles. When you're landing, everybody's eyes out of the helicopter because that's the most dangerous time, takeoff and landing. And so whether you're in one of these command center rooms or whether you're on one of your units or training your team, people's training has to kick in. And if you don't do this, people can easily get tunnel vision. People can easily have blind spots. And so we have to train to that standard, and it doesn't happen naturally.
Wonderful. Dr. Rosendale, I know when we were talking about this earlier, you talked a little bit about the military's philosophy on training for, which is similar to what Paul is talking about, that training for what could happen so that you're prepared for it when it does. And you talked about leadership within the military. Anything you want to add to this, or you feel like we've covered this between Susan and Paul?
Well, what I would add is both VA and DoD are pretty good about training up their people, taking care of their people. The truth is, during the pandemic, you needed to be 2, 3, 4 layers deep because somebody may have been exposed to COVID and they're in quarantine. And so we were constantly training people up to be able to backfill anybody that was gone. And so that's really important, certainly in the Department of Defense and also in the VA. We experienced that real time, and we spent a lot of time dealing with what Paul talks, those protocols. The guidelines were coming down. We were changing protocols all the time. We even had people that we brought on emergently to help with our screening procedures, people coming into the door into the hospital. Those protocols were changing almost every day. And so it is so important to have a training education system in place so that you can bring in people in a hurry and have all those guidelines and everything set up so that they can learn in a hurry. And so we did that, and like Paul said and Susan said, it's really important to use our information systems to be able to give them ease of access so that they don't have to struggle to find the information so they can make the decisions with the new training they get. And so it's so exciting. I see how the electronic health record participates in some of these things, but honestly, it's my finding the electronic health records, as you might know, I know a lot about those over the last 20 years, and they don't even come close to being able to be a command center, operational center to support these complexities. And so it's really, a great opportunity to harness all the information and the training procedures in place and build a smarter workforce in a hurry if you need to.
Fantastic. Well, we are down to the last 10 minutes and we've already got a number of questions in the chat. So I'm going to start with a couple of those and then we'll take questions from the audience as well. So the first one that came across from Sean was for Susan. And he said, thank you for sharing, Susan. Any uses for network management, example, early insight to clinical specialty, regional shortages, or referral leakage? So Sean, you may need to unmute if Susan needs more info.
Sure. So as far as network management, early insights, again, as I talked about, we had insights into now we could see in one place where we were losing business. And so we could add that on, those specialties on, to be able to get those specialties to keep that business. Really, with what we do, we're very active on our RAC in our region. And so we share a lot about what our healthcare system's doing. And so here in San Antonio, we share a lot of where our shortages are, OMF, those type of things, and then go back to our systems to try to figure out how we can bring that on in a business sense, because it's got to be able to pay, for itself to bring it on as well to provide care to those patients. Do you have any other particular questions around that?
Oh, Susan, that was great. Thank you for sharing that. It's a big area of interest. A number of folks that we're chatting with is frequently, and certainly during COVID specifically, there were so many people that were kind of moving on from the healthcare system, nurse shortages, and how do you get ahead of that? How do you start to get a sense that there's a trend? Regionally, we may be losing a particular specialty, which means we now can't serve the population in that area. It seems like an area that could be very data-driven and kind of known ahead of time. And then referrals is always an interesting one, right? So want to make sure that patients are being referred to places where they've got coverage and they're not being referred out of network. But then also make sure that the kind of the referral lines you're trying to build and make more resilient are being kind of followed and adhered to. So anything along those is kind of what I was interested in.
Yeah. For your staffing, having the predictability, being able to see that view of patients coming in and then predict, 24, 48, 72 hours out, having that visibility, as they spoke about, helped us with identifying our shortages, what we thought we were going to need nursing-wise. Of course, we never had enough. I think the other thing, when you talk about network integrity, one of the things that really helped us identify were those patients that were coming into our region or into our system from our region during the pandemic because they just didn't have pulmonology. They didn't have those specialties they needed. We were able then to work with some of those regions and put specialty clinics, because we really believe at Methodist that best care is local care. And so as we were being overwhelmed with all of those patients, we were really trying to support our referral facilities and keep giving them what they could use to keep their patients local as well, best for the family, and then to create capacity with us as well. So it kind of comes full circle, but being one center, you can see all of that coming in and identifying the need that's out in the community.
Super helpful. Thank you.
Thank you. Dr. Rosendale, we've got a question for you. So to get to the data sharing that you suggested, that sort of overarching data sharing where there was a number of different elements within that, is that the role, is there a role for the government at various levels to lead, or should it be led by the health systems themselves?
I think there's several layers of opportunity there. Certainly, the VA developed the joint longitudinal record, and they actually connected to the health information exchanges. I talked about there's over 400 health information exchanges that are connected to VA's joint longitudinal record, probably the most interoperable system in history. Not a lot of people appreciate that. So the government and the VA side is connected to that. So is the Department of Defense. I would also add that Health and Human Services reached out, and I know shameless plug for TeleTracking, but they have a contract to support all the acquisition of all the data relative to COVID in the United States from all the hospitals, or almost all the hospitals in the United States. That's where the government is reaching out and trying to get all the relevant information around COVID that they can use to be shared across the nation. And so that happens at the national level. I think the states are also interested in a similar model where they can actually capture all the data for load balancing across their state. I know my state, Colorado, the governor had an executive order to be able to load balance across the hospitals. The hospitals want to be empowered to make those kinds of clinical decisions themselves. And so with the private sector working with the government at the state, local, and national levels, and everybody on the same mission, I think is a really important factor. So the government can enable that kind of shared activity, and the private sector can feel empowered to be able to manage their own space. And so health information sharing, administrative sharing, access to vaccine, space, you name it. I think it's a private-public partnership model that we can actually endorse. And so I hope that answers your questions. I would say Office National Coordinator, some of the national offices I used to work with in DC, they're promoting interoperability using FHIR APIs and access the electronic health record solutions, or at least giving tacit service to being able to share information from their electronic health records. Some vendors make it a lot easier than others. I won't mention any names. But it would be nice to have an open, transparent model of access to relevant information for that national high reliability organization.
Thanks, Dr. Rosendale. That was fantastic. I know that we have just a couple of minutes left, and if there is additional questions, please feel free to either raise your hand or unmute yourself to ask those. You can also place those in the chat. I know Eli will make sure that we can get those information back to others. The last thing I just wanted to tie together on your conversation there, Dr. Rosendale, is oftentimes Susan and Dan's work that they do, it does break down those barriers, right? So how do they're sharing this information on a regional basis, sometimes a state basis, but your goal of having this on a national basis, that's certainly the ideal for us at some point. So I love that we have that conversation. Paul, Susan, Dr. Rosendale, any last thoughts as we wait to see if there's any additional questions?
Just maybe one comment to build on the data sharing component and the visibility of data that Doug and Susan were referencing. Both Susan and I have spent quite a bit of years on journeys on building these types of rooms. And we want to encourage folks, if you don't have this type of room, what Doug was saying, every other high reliability industry, nuclear power, air traffic control, NASA, and again, remember, healthcare is more complex than that, have an operations center. That's a common element of all of those high reliability organizations or industries that need to be high reliability. So we encourage you to organize yourself in a way that makes sense, not to just throw people together, but put people together in a way that can share information in the way that Susan was talking about, and creates this kind of network and systemness. You only can see the system if you have the elements of the system, again, that Susan was referencing. One hospital making one decision here could have a ripple effect for multiple hospitals that they don't see. They could create a problem for other hospitals that they don't see. Something as easily as staffing or capping a bed or a certain type of level of bed could have a ripple effect through that. We've seen that in our systems. In our system, personally, we've seen that. So again, just in the way that you can share data and have a national platform for data, you can also have these rooms that can have common language, common terms, common functionality, so that I guarantee you our center in Virginia could call Susan's in Texas and have a equal conversation, and we could easily share the same information. So our vision, I think, is also people, technology, processes all together in rooms like this allow a network to be created so that in an emergency, like you see a pandemic, they all can connect together very quickly and get the same level of information.
Fantastic, Paul. That was a great way to end. I think you hit on all 5 of the HRO principles there: sensitivity to operations with that heightened awareness of the state of relevant systems and processes, that preoccupation with failure, viewing those near misses as an opportunity to improve rather than proof of success, reluctance to simplify, so accepting that the work is complex and that it's likely any of the things that we think are going to happen are probably going to change, that commitment to resilience and prioritizing that emergency training so that when it happens, it feels commonplace, and that deference to expertise. So ensuring that it's not just a hierarchical view of who's in charge, but, bringing those folks to the future or to the top that have the expertise. We are right at time. Eli, anything else that you wanted to add?
No, I just wanted to say thank you to our panelists. Thank you to you, Michelle, for moderating, and thank you for TeleTracking for being a partner with us on this. So thank you, everybody, for joining.